myths of AKI, and the next topic is a very special aspect of the AKI, because we have seen over the years that the spectrum of AKI is changing in our society. A couple of decades back, uncomplicated medical causes used to be the commonest cause for AKI, of which volume depletion, gastroenteritis, obstetric cases, drugs used to be the main causes for AKI. But over the years now we realize the advancing in the intensive care management, extensive use of drugs, aggressive management of various complications in the hospital setting, we are getting more and more complicated cases of AKI. And obviously, the AKI in the setting of an intensive care unit, which is multifactorial, multifaceted, and with the risk of progression to CKD has been the main problem for most of our nephrologists. So now, today we are going to discuss in a special situation in MICU, AKI, by Dr. Vishwanath. I request Dr. Subbarao to introduce the speaker.
Yes, my pleasure to introduce Dr. Vishwanath. He is a pediatric nephrologist and a specialty in the nephrology field, and he is from basically from Karnataka. He's passed out from Davangere Medical College, and then he did his DM and the MD, and then the EMD nephrology in Manipal Hospitals, Bangalore. A lot of interest in intervention nephrology, pediatric nephrology, renal transplantation. So if you want to have a look at his complete profile, it's available on your tablet. And it's over to Vishwanath to proceed with his talk.
Thank you, sir, for the wonderful introduction. Good afternoon, all of you. Respected chairpersons, my dear teachers and friends. At the outset, I would like to thank the organizers for giving me the opportunity to address the gathering. My topic for today will be AKI and MICU. I'd like to cover the topic the following headings: the special emphasis on what are the recent advances, what has been our experience, and what is going to be the future trend. AKI, as all of us know, is common in hospital admissions. It is apart from ICU. So as the data shows, almost 5 to 7% of admissions itself can have AKI. In an ICU setting, it can go up to 5 to 25%, and 6% of them requiring RR. Mortality does not change over so many decades. In an ICU, the person with acute injury and multi-organ dysfunction, mortality can go as high as 80% if there is a need for RRT. There has been an increasing awareness of people recognizing that even minor changes in serum creatinine are associated with increase in mortality. As we all know, ATN is the most common cause of hospital-acquired AKI. In ICU, as the chairperson just described, ATN is usually multifactorial. As of now, there is no specific formula for treatment which is effective in treatment of established AKI except supporting them with the help of RR. This is the picture to show the mortality can be as high as 80%, 60 to 70% in people who are on dialysis. There are a lot of classifications proposed over these decades. The accepted ones, which are popular and quite clinically relevant, are rifle and Akin classification. Rifle classification, all of us are aware. Akin classification is nothing but a modification of rifle by Akin group, which recognizes again the smaller changes in serum creatinine as small as 0.3 as adverse clinical outcome. This uses serum creatinine, urine output, and time duration as the base. This is Akin classification. So according to the KDIGO, the definition of AKI is increase in creatinine by 0.3 or more within 48 hours, or an increase in creatinine by at least 1.5 times from the baseline within 7 days kg per hour for 6 hours. There have been more than 35 definitions of AKI published. This has been the accepted guideline by KDO, which was published in March 2012. So now, where are we? For diagnosing, basically, we are dependent on serum creatinine, urine output, and the time duration. Nothing else. We all know the common causes. Increasingly, sepsis is becoming much more common compared to earlier times. The sepsis majority of the studies show is increasing from 50 to 60% of the cause in AKI in ICU. The other causes include hepatorenal, of course, the recently recognized entity of abdominal compartment syndrome, nephrotoxins, all of us are aware. People are becoming more and more aware of nephrotoxins, especially in ICU setting, so there has been less cause for nephrotoxins leading to AKI. How do we prevent AKI? First and foremost is to recognize the risk factors for people who develop AKI, like diabetes, chronic kidney disease, elderly age group, cardiac and liver dysfunction, and pregnancy. The maintenance of renal perfusion is of utmost importance to prevent the occurrence of AKI, avoidance of hyperglycemia, and avoidance of nephrotoxic drugs. Prevention of contrast nephropathy, all of us are familiar with. Basically, volume expansion, whichever way we want to, and usage of N-acetylcysteine and avoidance of concomitant use of nephrotoxin drugs. How do we prevent AKI hepatic dysfunction? There are a lot of trials which have shown recently IV albumin significantly decreases the incidence of AKI and mortality in cirrhotic patients, either with or without SBP. IV albumin again reduces the incidence of AKI after repeated large volume paracentesis. IV albumin together with erythromycin definitely decreases the mortality in HRS. How do we manage AKI in ICU? First and foremost is to maintain the renal perfusion, correct the metabolic abnormalities as they arise, provide adequate nutrition, maintenance of oxygenation, and morning relaxation. Dr. Muthiral explained the role of diuretics, which most of us are very comfortable using, except that it will convert from oligural renal failure to non-oligural renal failure. It doesn't really make much of difference in mortality and need for RRT. How do we maintain renal perfusion? Hemodynamic stability and avoiding volume depletion is of importance. Most of the studies have undermined the importance of maintaining the mean arterial pressure of more than 65. Volume resuscitation, again, morning there was stress on SAFE study, which really didn't show any statistical significance between saline and albumin. In fact, it was a negative trial where it showed albumin was assured higher mortality in people with traumatic brain injury, except there was a small improved survival in people with septic shock. How much fluid should we give for these people for one resuscitation? Now it is generally accepted all over, especially with the nephrology group, that fluid therapy should be conservative but not too much, because conservative fluid therapy definitely decreases the need for ventilator support, doesn't increase the need for RRT, ARDS, and there is a definite association between positive fluid balance and increased mortality in AKI. Which inotrope is best? Still there is no evidence saying one is superior or other. Probably there is some role of vasopressin in patients with sepsis. Renal vasodilators, definitely dopamine has a negative significance in people who have AKI or going to develop AKI. In fact, it may worsen renal perfusion in critically ill patients, and it is known to cause atrial fibrillations and other cardiac complications. Once the AKI is already established, all the volume resuscitation has been done, all the preventive factors have been addressed, there is an established AKI, where do we stand? What is the next therapy? What is the timing of initiation? How much dose is adequate? We'll see if we can answer these questions. Definitely there is some evidence to start higher therapy dose with a better outcome, at least up to some extent. no definite evidence on exact timing of initiation of RRT. All of us are aware of proposed indications, absolute indications being one of more than 100, dyslipidemia, severe metabolic acidosis, and a diuretic-resistant fluid overload. To briefly describe the major renal replacement therapies available, intermittent therapies, continuous therapies, and there has been an increasing trend towards hybrid therapies, that is, sustained low efficiency daily dialysis with or without hydroxyurea. What is the argument for intermittent therapies? Relatively inexpensive, gives flexible timing so that the patient, if he needs any mobility or transport for any imaging, will be allowed. It leads to rapid correction of fluid and electrolyte abnormalities, minimizes anticoagulant exposure. What are the arguments against? There is significant amount of hypertension as high as 60%, which may limit the therapy duration, which may perpetuate renal injury and ischemia, which may increase gut and coronary ischemia. And people with cerebral edema in situations like ectorenal syndrome, brain trauma, it may be detrimental. What are the arguments for continuous therapies? It gives more freedom in hemodynamic unstable patients. It gives stable and predictable volume control and biochemical control. It can be easily used in people with intracranial pressure, high pressures. The argument against anticoagulants are definitely required with the increased risk of bleeding, especially in people who are already having sepsis, DIC, who have increased risk of bleeding. Heparin exposure, of course, can increase the chances of hit. High potential for filter clotting, and definitely in our country expense is a significant negative factor for continuous therapy. The various therapies discussed, the main objective is volume control, CVVH where convection comes into play, CVVHD in diffusion, HDF where diffusion and both are effective. This has been our experience with the CRRT. These are our oldest machines called Infomet. I don't know how many of you might have seen. Initially it was commenced in 2000. Almost they have run out of their life now. We no longer have these machines. Very versatile, user friendly. The only advantage of this machine is you can prepare your own replacement fluid. You need not be dependent on commercially available one, hence cutting the cost. This, all of you might have seen, Prismaflex. The problem with this machine, expense. The kit itself is expensive. Apart from the need to use the commercially available replacement fluid, you cannot prepare your own in-house replacement fluid. This is the newer one called 5008, which we have two of it now. It will use the dialysate to prepare replacement fluid. There is no need to use separately replacement fluid, hence cutting the cost, which is a significant factor in our country. You can use how much volumes you need, HVHF, whatever extent you need. But only thing is you need to have an ultra-pure water treatment plant. There are two pumps, other pumps are inbuilt. There has been an increasing favoritism for sustained low efficiency dialysis because one is cost and we can do the therapy conventionally available dialysis equipment. You don't need any specialized equipment or personnel. The cardiovascular stability is almost similar to CRRT. The recent study showed 11 hours of sleep was comparable to almost 23 hours of CVVH, hence decreasing the cost. If we compare all three modalities with respect to clearances, CVVH and SLED are almost equivalent with respect to effluent volume. Of course, middle and larger molecule clearance is better than CVVH. Whether it is completely beneficial or not, still the controversy is going on. So if we compare continuous therapies and intermittent therapies, continuous therapies are probably more suitable in specific indications like hemodynamic instability, ectorenal syndromes, raised intracranial pressures, severe volume overload. The recent meta-analysis by Baksha and Ramko showed lesser hemodynamic stability and better fluid control with CRRT. Picard study again showed CRRT was able to remove extra fluid in severely volume overloaded AKI patients. The recently concluded ADN and renal studies showed vasopressor dependent ICU patients on CRRT less frequently awarded to chronic dialysis compared to intermittent dialysis. Two recent RCTs did not show any superiority of CRRT. Hence, the KDIGO guidelines have given both CRRT and SLED the same level of evidence. What are the outcomes? This was hemodialysis study which showed the 60-day mortality was similar in both the groups, intermittent and continuous. The dosage again, this was the initial study which gave NGM saying daily dialysis is better, and the landmark, I think all of you would have known, Rompo study saying the amount of volume as we increase effluent volume, the survival was better. Hence, Rompo and other studies showed the increasing the convection dose and adding dialysis improved the outcome, but the renal study published in 2008-9 showed no beneficial effect from increasing 25 to 40 ml in non-septic AKI, including NIT dose mortality. Whether septic AKI needs higher dose, we'll come to it later. The Veteran Affairs and NIH sponsored study, which was a multi-center study where more than 1,000 patients were included, had two arms, an intensive group and a less intensive group. In intensive group, they did either intermittent dialysis, SLED 6 times per week, or CVVHDF at 35 ml per kg per hour, depending on the clinical situation. Less intense group had intermittent therapy or SLED 3 times per week, or CVVH at lesser volume, that is 20 ml. The primary outcome was mortality, which was not significant. The secondary outcome was duration of RRT, rate of recovery of renal function, and other organ failure. Again, it was not significant. This to show there is no significance of the mortality at 60 days in either intensive group or less intensive group across both hemodialysis, intermittent hemodialysis, and CRRT. Coming to the type of dose, the amount, the current consensus is to advocate hemofiltration dose of 27 per kg per hour, which has been the KDIGO guideline. In practice, what happens when we prescribe CRRT, the prescribing of 30 to 35 ml per kg per hour will account for predictable breaks like nursing, drug administration, unpredictable breaks like suppose the patient has sudden clinical deterioration, you need to have a scan, or bitter clots that may come in the way of the therapy. So prescribing a 30 to 35 ml may ultimately deliver an effluent volume of 25 ml per kg per hour. There is a recent trial which is ongoing. This is only a preliminary result called IVL study, where they had very high volumes of 70 ml per kg per hour in sepsis patients, which showed a significant difference. This is not completely published yet. Coming to the timing of CRRT, most recommend RRT to begin early before the AKI completely progresses and the patients become more sicker. It is acceptable generally to initiate RRT when a patient is in the rifle injury group or acute stage 2, especially in septic patients. Probably it is more relevant in pediatric population, people who are ECMO with ARDS and fluid overload. Again, morning the study was quoted. The SABRE study, the recent one, clearly favored an early timing. We should not forget, whenever a patient is on CVVH, we should also account for the medications delivered and dosage has to be administered appropriately. So what are the implications of the available data? AKI is not just an innocent bystander in ICU. All efforts should be made to prevent AKI. We should ensure there is an adequate dosing of RRT. With respect to especially, there should not be underdosing. The choice of RRT modality may not be very critical, depends on the center's preference and expertise available. Probably septic AKI is a completely different piece which has to be dealt with short, when the rifle study came initially, we prospectively stratified 100 patients for the rifle criteria. The mean age was 49.5. Depending on the severity of renal failure, definitely the length of ICU stay, the length of hospital stay, and the need for iron probes definitely increased. RRT was required in 39% of the patients, with overall mortality of 33% who needed RRT. Mortality, of course, was highest in the F group. At the end of 3 months, we had 6 deaths. 2 patients continued to be dialysis dependent. Serum rate at discharge was significantly higher in failure groups. Overall, failure group had longer need for anatropes, ventilator support, ICU, and hospital stay with a higher rate at discharge. Diagnosing the AKI, early biomarkers, studied at Ramesh, has alluded to, probably all put together, NGAL, IL-18, KIM, may make some sense rather than individual molecule. We had our short with NGAL, which is an ongoing study. It was done in patients who were electively going for cardiac surgery. 47 patients were included, 42 have completed the study. 18 of the patients had AKI. NGAL negative patients did not require dialysis. NGAL positive patients were 3. 2 of them had severe AKI needing dialysis. This is a very small number to come to the conclusion. Of course, there are a lot of newer avenues available like heme absorption and other therapies, coupled plasma filtration. The recent study showed higher cutoff filter with more than 60 kilodaltons with promising results. Whether these techniques are helpful only with the later trials are going to show. To conclude, there are exciting newer targets which have not gone into details for the lack of time, mainly caspase inhibitors and interrenal inflammatory pathway inhibitors which have shown different good results in animal models. Hemofiltration has a definitive role in AKI, sepsis and other inflammatory mediators. 35 ml should be considered as a different volume per kg per hour in septic patients, and in non-septic probably 25 ml per kg per hour would be sufficient. In future, different techniques are likely to expand the spectrum in therapy, especially in sepsis. Type of therapy should be always individualized based on resources available and to the local needs. There is definitely a need to expand our knowledge on AKI to reduce the mortality which is still very high in the present time. Thank you very much.
Various types of modalities available and trying to compare the SLED versus the. But as your experience with SLED,
Actually, in our study now, you see the numbers. Almost 50% of our patients are currently ongoing with the SLED. Our number of CRRT has come down. That is because one is cost and SLED, we are not compared directly head to head. SLED has shown similar results.
The literature finds SLED is more practical in our setup.
In our country, especially, yes.
Yeah, we've been using both the systems, but when it comes to very sick patients, we tend to use CRRT and SLED. So there is a little bit unclarity because these things are not very clear. A very sick patient using CRRT, SLED has any, so SLED is equal to CRRT or not, but at a moderate risk patients, I think CRRT and SLED has got the same results. I think with this we conclude this session and we proceed to the lunch.
Thank you, sir. Thank you so much. I request Dr. Thank you, sir. I request Dr. Chiranjeevi to come out to the dais and present the program to Dr. Suppa. Thank you, sir. Thank you very much. That was the pre-lunch academic session for us because of the paucity of time. It's a
important session. Dr. Raghu Kalluri has to introduce himself. As you all know that the fibrosis is the final common pathway for all kidney diseases irrespective of the etiology, which can lead to rapid decline in the kidney function and majority of the going to end-stage renal disease. So, by so many methods that are under experimental trial, we have to reduce the production of transforming growth factor beta, and some anti-fibrotic factors are there. Thereby, we can reduce and decline in the to minimize the number of kidney patients to reach the end stage renal disease. So, by which we can to minimize, we request Dr. Chakor Gaze to introduce our Dr. Raghu Kalluri.
Dear friends, it gives me great pleasure to introduce today's speaker, Dr. Raghu Kalluri, MD, PhD, who is Professor, Department of Cancer Biology and Chair, Department of Cancer Biology at MD Anderson Cancer Institute, Houston, Texas.